Our next topic for discussion is anxiety disorders. The first thing I thought we would talk about would be panic attacks. Panic attacks are when people have a sudden, unpredictable onset of intense fear. So it's pretty hard to understand what the stimulus is sometimes for panic attacks. Things that you might try as a nurse if a patient has a sudden panic attack. Sometimes having them take slow, deep breaths will help. If they go into respiratory alkalosis because of hyperventilation, you might have them use a paper bag so that they're rebreathing CO2. Distracting so that their thoughts are someplace else other than on their panic sometimes is of assistance. Let's take a look at a question. An adult is admitted to the psychiatric unit for treatment. For several weeks, he has had increasingly frequent periods of palpitations, sweating, chest pain, and choking. The nursing diagnosis is severe anxiety, stressor unidentified. Which of these measures is appropriate during an anxiety attack? Number 1, supporting and protecting him. 2, engaging him in socially productive behavior. 3, having him review the circumstances that brought on the symptoms, or 4, ignoring him until the symptoms subside. So the question asked us during an anxiety attack, and the patient is described as having chest pain and choking. The answer is number 1, supporting and protecting him. Let's do one more question. A 35-year-old woman is brought to the emergency room by her husband. She complains of heat, diarrhea, dry mouth, and shortness of breath. She says she is having a heart attack or a nervous breakdown. What should the nurse do first? 1, assess her physical and emotional state. 2, decrease her anxiety level. 3, find out what triggered her symptoms. Or 4, approach her about seeking therapy to explore her behavior and feelings. And the correct answer is number 1. First, you should assess. Remember that assessment is the first step of the nursing process. Let's take a look at some anti-anxiety medications. The benzodiazepines are a large family of drugs that are often used for anxiety disorders. Notice that most of them end in azepam. Diazepam is Valium, very commonly used anti-anxiety agent. Ativan is lorazepam. Now, there are also some drugs like meprobamate, which used to be extremely popular, that are used as anti-anxiety drugs. And sometimes the sedating antihistamines, such as Vistaril or Atarax. These are drugs, hydroxyzine. Now, if we talk about these drugs, major side effects of these drugs include sedation. So be careful when patients are driving until they know the effects of these drugs. They can also cause the anticholinergic side effects, the red hot, dry, blind, mad side effects that we've talked about so frequently. These drugs can be used for people with various types of anxiety disorders. I want us to take a look now at patients with phobias. A phobia is described as an irrational fear. There are a number of types of phobias. Simple phobias are when people are fearful of an object like snakes or spiders or mice or roaches. These are classified as simple phobias. Lots of people have simple phobias, and they're perfectly normal people, actually. Agoraphobia is literally fear of the marketplace, fear of open or public places. Claustrophobia is fear of enclosed or small places. People with claustrophobia are often fearful of riding in elevators, for instance. Now, it is thought that the defense mechanisms involved are first repression, which is involved in virtually almost all of these anxiety disorders, and then displacement, so that the original fear may have been of one thing and it's often displaced onto some type of object or situation. When people have phobias, there are a number of things that we can do in the management of phobias. They might be getting anti-anxiety meds like we just talked about. We might use gradual desensitization, which means that, let's say they're scared of elevators. So we get the person to stand outside of an elevator, and we discuss and talk with them. And then maybe in a few days, we stand outside the elevator with the door open. Then maybe we stand inside the elevator with the door open and it doesn't go anywhere. Then maybe we go one flight on the elevator. So a gradual desensitization process can be used. Behavior modification is another one, rewarding the desired behavior. Relaxation techniques. What we know does not work is reasoning. This fear is coming from the unconscious mind. And so trying to tell people that snakes are not going to jump out and hurt them, that there's no reason to be fearful of the snakes, to have this irrational fear, doesn't work. So reasoning, logic don't work in terms of dealing with patients with phobias. We also don't want to force confrontation with the objects or situation that causes the intense fear reaction. Let's look at a question. An adult is admitted because she has an intense fear of elevators. 2 days after admission, she is scheduled for group therapy, which meets on the 6th floor. Her room is on the 2nd floor. She starts trembling and refuses to get on the elevator. Which nursing action is therapeutic? 1. Firmly insist that she get on the elevator with the other clients. 2. Explain to her that the elevator is safe and take her on a separate elevator. 3. Excuse her from group therapy until she will get on the elevator. Or 4. Assign someone to walk up the stairs with her. And the correct answer is number 4. Now note in the question that this is 2 days after admission. This tells you that she's not yet had a chance to have the therapies be effective. So don't say, well, what if she's over her fear? She's not. And we know that because of the time in the question. So don't force her to confront that. Have someone walk up the stairs with her. Let's look at yet another question. After the nurse has had several brief conversations with a newly admitted client, she suddenly says, "I'm afraid to ride in an elevator. I know it's silly, but I can't help it." Which of these responses by the nurse would be the best example of acknowledgement? 1. It's hard to manage without using elevators. 2. Being afraid to ride in elevators seems unreasonable to you. 3. Perhaps you should consider why you were afraid to ride in an elevator. Or 4. The speed of elevators frightens you. Now the stem of the question asked us for the best example of acknowledgement, and that is number 2. Being afraid to ride in elevators seems unreasonable to you. The patient said, "I'm afraid to ride in an elevator. I know it's silly, but I can't help it." Seems unreasonable to you. So the correct answer is number 2. Let's look at another type of anxiety disorder, and I want us to look at obsessive-compulsive behavior. With obsession, there's some kind of uncontrollable recurring thought that you're going to do something, something is going to happen to you. And the compulsion is a ritualistic act that's done in an attempt to relieve the anxiety related to this compulsion, to the obsession, to the thoughts, to make the thoughts go away. The patient may not be consciously aware that that's what the ritual is for, but the underlying purpose seems to be to make those obsessions or those thoughts go away. When taking care of patients who have obsessive-compulsive behavior, we don't interrupt the rituals. We may set limits on the rituals as to how frequently they can do them, but we need to allow time to complete the rituals. If you interrupt it, you'll send them into a panic attack. We may try distracting, desensitization, behavior modification. All can be used to help with obsessive-compulsive behavior. Sometimes people who are doing repetitive washing actions, which are very common with obsessive compulsive patients, may actually need good skin care because their hands may be the skin may be broken down from the repetitive washing. So there may be actual physical protection from these repetitive acts. Hopefully, you allow a chance for the patient to express their anxiety in more appropriate ways. They may be candidates for individual therapy, group therapy. The drug anafranil is used in some patients, but patients who are obsessive compulsive, we may help them to get the compulsion manageable, but they may tend to be somewhat obsessive compulsive the rest of their lives. Hopefully, it's not going to be the point where it interferes with function. Let's look at a question. A young woman is being admitted to the psychiatric unit. She's been having recurring thoughts about hurting her baby boy. She states she washes her hands all the time. Which statement would she be most apt to make at this time? Now, just a word on this one. At this time, notice, look back. This is while she is being admitted. So the answers would be, number one, I know it's silly to wash my hands so much, but I just can't help it. Number two, if I keep washing my hands, I won't hurt my baby. Number three, I need to wash away my sins and guilt. Or number four, washing my hands is important to protect my baby. So upon admission, before the patient has been treated, what this patient is most likely to say is choice number one. I know it's silly to wash my hands so much, I just can't help it. So the person rationally, consciously knows this doesn't make sense, but this compulsion is coming from the unconscious mind. So they say, I just can't help it. I have to do it. I have to wash my hands. They are not likely to have the insight to realize symbolism and what this might mean, nor are they likely to say they're doing it just to protect their baby so they don't give the baby germs, for instance. They're more likely to say, I know it's silly, but I can't help it. Another question for us. Which of the following is an example of limit setting as an effective nursing measure in ritualistic behavior patterns? 1, I don't want you to wash your hands so often anymore. 2, if you continue to wash your hands so often, the skin on your hands will break down. 3, you may wash your hands before the group therapy meeting, but not during group therapy. Or 4, you will be punished if you wash your hands more than 6 times a day. And the correct answer is number 3. This sets limits. It says you may wash your hands, but it defines the time. Before group therapy, but not during group therapy. Let's take a look at a question. An adult is hospitalized with injuries following a tornado in which her home and many others were destroyed. She starts to cry and says, "It was so awful. I can still hear that terrible roar." What is the best nursing response? 1, don't think about that anymore. It's over. 2, why do you think your house was hit by a tornado? 3, tell me what happened. 4, it's all over now. Think about pleasant things. And the correct answer is number 3. You'd like to open communication and encourage the patient to talk about their feelings. This patient is suffering from post-traumatic stress disorder. Now, PTSD, or post-traumatic stress disorder, is when a patient experiences some type of traumatic event that's worse than people should normally be expected to endure. So it could be a natural disaster, such as in the question we just did, tornadoes, hurricanes, floods. It could be fires. It could be war-related PTSD. That's a very common cause of post-traumatic stress disorder. When patients develop PTSD, they often end up with trouble sleeping. They may wake up in the middle of the night with nightmares, and they're right back in the traumatic situation, be it the natural disaster or the wartime situation. Many times these patients will avoid any kinds of activities that might recall this event. They have a problem with interpersonal relations. Frequently they will end up having multiple marriages and divorces. They often get flashbacks. So if a person had war-related PTSD, for instance, they might hear a car backfire and they literally dive under the table because they're convinced it's incoming rounds. Many of these patients are depressed. Oftentimes they go to substance abuse to help them cope with their feelings. We know that they're using a lot of denial and repression. Now, when we think about what would we do for patients with PTSD, the first thing would be to try and prevent it from becoming a full-blown case, such as that question we just did with the patient with a tornado that had experienced a tornado. We would encourage them to talk about their feelings about the trauma and try and talk about it until they can diffuse their feelings. Many of you may recall when you've had some type of trauma, probably not as major as the tornado. Maybe you had a little fender bender accident. And for the first few days, every time you closed your eyes, you were right back there and you were experiencing that fender bender. And you talked about it to everybody. You told everybody that would listen to you what happened to you and how awful it was. And after a few days, you didn't even want to talk about it anymore because you'd spent all the emotion dealing with that. Now, PTSD, this is multiplied many times, but the principle is still the same. Encourage the patient to talk about their feelings. Eventually, this may diffuse the feelings. We want to encourage them to share their feelings with their support systems. Now, please be non-judgmental as you listen to them. I think about a person who stopped in my office one day, saw some of my certificates and things on the wall. He knew I was a nurse. And he looked at that and he said, were you in the Army Nurse Corps? And I said, yes. And he said, were you in Vietnam? And I said, yes. And I said, were you? And he said, yes. And then he proceeded to tell me what he did in Vietnam. And to make a long story short, this man had the job of driving a truck around the battlefields, picking up dead bodies. And he talked and he talked and he talked, and I used my very best communication techniques, and I was non-judgmental. And he told me about what went on, and then when he got done, he said, you know, that's the first time in 20 years that I've talked to anybody about that. Now, this man had had 2 or 3 marriages and divorces. He had overcome a medication or narcotics addiction problem induced in part by his war injuries. He was now a compulsive gambler. He's unable to keep a job. He was in and out, started 2 or 3 different businesses over the course of several years. Now that shows you what PTSD can do to you and the fact that he wasn't able to talk about that. So encourage people to talk about their feelings. That will diffuse them, and hopefully it won't disable them in their life. We have people with PTSD who date back actually to World War II, and those people who experienced extreme trauma during World War II. So you could see PTSD questions about patients, war veterans, or a natural disaster type of situation. We also see PTSD-like responses following rape. Now, I want us to talk about some other disorders that are classified as anxiety disorders, and these are somatoform disorders. Soma means body, so these are disorders in which you have bodily symptoms that are caused or aggravated by emotional problems. The first thing you have to do is rule out actual disease, and this is problematical, so you have to make sure that there's not a physiologic disease that's being ignored. Once we've determined that the cause is most likely a somatoform type of disease, we want to make sure we do not focus on the physical symptoms. So we don't go in and say, oh, how are your heart palpitations today? because that draws attention to it. So we don't focus on the physical symptoms. We don't want to be over attentive. We want to make sure they've got accurate information about any problems they may have. Now, probably one of the most important things is to discourage secondary gains. Secondary gains are the benefits you get from being sick. Now, most of you have known people who use this, secondary gains. They would, you know, Aunt Susie, now be careful. Don't upset her. You know her blood pressure. You don't want to raise her blood pressure and give her a stroke. Or maybe, Uncle John, don't argue with him. Just do whatever he wants. You know his ulcers. He has such terrible time with his ulcers. So those would be secondary gains where people use their illnesses to get attention and special kinds of treatment. Hopefully we can work with patients to develop better coping mechanisms and maybe even divert their thought processes from their body reactions. We're going to look at another question that introduces yet a different type of anxiety disorder. A young man was diagnosed with a conversion disorder. He was brought to the hospital blind after having seen his 3-day-old son breastfed. Which of the following is the best interpretation of this data? 1, I don't like this infant. 2, I do not want my wife to have such close contact with the child. 3, I don't want to see this act of nursing. Or 4, I wish I had never had a son. Now, if we look at this question, what do we know? We know simply that the man became blind when he saw his infant breastfeed. We know nothing else. So the answer to this question is number 3. I don't want to see this act of nursing. We do not know why. It probably actually has nothing to do with this baby. It more likely is related to something that happened in his past, probably in his childhood. Now, with a conversion disorder, the patient has the sudden, dramatic loss of motor or sensory function. Usually there's a trigger of some kind. They have this sudden loss of motor or sensory function, and they don't care. That la belle indifférence, the beautiful indifference, they do not care. And the reason they don't care is that unconsciously what's happening is this loss of function is taking them away from the anxiety trigger. So, for instance, this man who became blind when he saw his baby breastfeed, there's some kind of, probably in his unconscious mind, some kind of trauma associated with seeing breasts or breastfeeding babies. And it's so traumatic to him that his unconscious mind says you'd rather be blind and see nothing than watch this act of breastfeeding. You might have a patient who is very unhappy in their job, extremely unhappy in their job. And their job is data entry. So they're doing data entry all day long. They've got a very mean boss. It's a terrible job situation. And one day they wake up and both arms are paralyzed from the elbows down. Now, physiologically, this doesn't make much sense. Both arms paralyzed from the elbows down. It doesn't follow neural pathways that way. And they don't really seem terribly upset by it. What it does is it keeps them from going to work. Now, this is one of the types of anxiety disorders that's usually very treatable. Usually some psychotherapy, we can get to the underlying problems, and it's usually short term. So that within a few months, and that's short term for psychiatric illnesses, within a few months, many times the conversion disorder problem has been alleviated with the proper kind of therapy. Another question for us. A client with severe anxiety manifested by many somatic or body complaints starts psychotherapy. She becomes increasingly anxious and her physical symptoms intensify. The nurse should make which of these interpretations of her observations? The client, 1, needs to be involved in modifying the goals of therapy. 2, may be developing a physical illness unrelated to her emotional problems. 3, is responding to therapy as expected at this time. Or 4, is probably beginning to develop insight into her behavior. And the correct answer is number 3. Frequently when people start therapy, the goal of therapy is to bring the unconscious conflict to the conscious mind. So when they start psychotherapy, they're apt to get more anxious before their anxiety begins to dissipate or go away. So the correct answer was number 3. This is a normal response to the initiation of psychotherapy. Now you might have some questions that relate to psychological aspects of physical illness. So a couple of ways we could see this type of thing. Many illnesses we know are physiological illnesses, but there may be emotional triggers or emotions may make them worse. Asthma, for instance. We've got a physiologic process going on, but many times emotions can trigger an asthmatic attack. Things like migraine headaches and even high blood pressure, ulcers. There are physiologic problems going on, but emotions can aggravate those symptoms. So when we have an actual physiologic disease process, first you care for the physical symptoms. Remember Maslow, physiology before psychology. Then we may encourage some discussion of the stressors, things that aggravate the condition, and hopefully work on helping the patient develop alternative coping mechanisms. Let's look at a question. A client with cancer states he has no reason to live anymore. What is the most therapeutic response for the nurse to give at this time? 1, you feel as though you have no reason to live. 2, your wife needs you and wants you to live. 3, your children care about you. 4, I care about what happens to you. Now the correct answer that's most therapeutic is number 1, because this encourages the patient to talk about his feelings. And that's always a therapeutic response, letting the patient talk about their feelings.